It is my pleasure to be the first speaker of this workshop. My name is Sung Kim, Professor Emeritus of the Radiology and Urology at Seoul National University Hospital. And now I'm running K-Radiology Clinic, and this is the last day of my work from presidency. Nutcracker syndrome is caused by the compression of the left renal vein between the abdominal aorta and the suprameningeal artery, causing left renal vein compression and resultant hematuria, proteinuria, and flank pain. The name of this syndrome was first used by Dr. De Schepper in 1972. Two terms, Nutcracker phenomenon and Nutcracker syndrome, should be used separately. Nutcracker phenomenon is just a phenomenon of left renal vein compression, while the term Nutcracker syndrome is used when a patient with Nutcracker phenomenon has symptoms or signs. Dr. Skollbacher proposed an interesting concept, so-called midline congestion syndrome, that may explain a wide range of symptoms of Nutcracker syndrome by numerous collaterals of left renal vein crossing the midline. It suggested acetylsalicylic acid or aspirin may be helpful in those symptomatic patients. Now, first question is, how common are these phenomena and syndromes? It has been thought rare and is registered as a rare disease in NIH or orphan sites of the United States, but I think it is probably not rare and is quite common. The reason why it is non-rare is probably that definitive diagnostic criterion is more than 3 millimeter mercury pressure gradient between the left renal vein and the inferior vena cava, which needs invasive venous catheterization and venography. However, Doppler ultrasound is an excellent technique in detecting Nutcracker phenomenon by using 100 centimeter per second velocity criterion of the left renal vein. My experience of Doppler ultrasound of the left renal vein in 1,223 patients in my clinic was presented in 2020 KSUM Congress, and the data showed approximately 30% prevalence of Nutcracker phenomenon, and approximately half of those Nutcracker phenomenon cases had symptoms or signs, so they were Nutcracker syndrome patients. Both Nutcracker phenomenon and Nutcracker syndrome cases had a slight female predominance. So Nutcracker phenomenon and Nutcracker syndrome are not rare, but are quite common. The next question is how various. This is a classical example of left renal vein compression between the abdominal aorta and the suprameningeal artery, but there are many other variations. In this case, left renal vein is not compressed between the abdominal aorta and suprameningeal artery, but is compressed by the origin of the right renal artery posteriorly. This is a very common variation of the Nutcracker phenomenon. Here's another variation, and the left renal vein is not compressed between the aorta and suprameningeal artery, not compressed by the right renal artery, but is stretched over the prominent abdominal aorta. This is another variation. This is another variation associated with the congenital left renal vein anomaly. It's a retroaortic left renal vein, where left renal vein is compressed between the vertebra and the abdominal aorta and is called posterior Nutcracker. Another variation associated with venous anomaly, left-sided inferior vena cava. In this variation, blood from the left kidney should compete with a large amount of blood flow from the left lower part of the body, and so it causes not anatomical but functional Nutcracker phenomena. Next question is how interesting. The first interesting thing is the postural variations of Nutcracker phenomena. The supine, left lateral decubitus, and the right lateral decubitus. In this patient, the left renal vein compression is much less severe in both left and right lateral decubitus postures than in a supine posture. In this patient, the mesenteric root having superior mesenteric artery is widely movable with postural changes. In left lateral decubitus posture, the superior mesenteric artery is here and the left renal vein is not compressed with the normal flow velocity 49. But in right lateral decubitus posture, the superior mesenteric artery moved back to the pre-aortic location, and the left renal vein is similarly compressed with the supine posture. And so it is easy to recommend this patient to have the habit of sleeping in left lateral decubitus posture rather than supine or right lateral decubitus postures. In this patient, if you see the location of the superior mesenteric artery in supine, in left lateral decubitus, and in right lateral decubitus postures, you may notice the limited movability of the mesenteric root, and the degree of compression of the renal vein is similar in all three postures. This is a case of left renal vein stretched over the prominent aorta, and the degree of left renal vein compression is similar in all three postures: supine, left lateral decubitus, and the right lateral decubitus. Another interesting phenomenon is the respiratory variation of the Nutcracker phenomenon. If we compare the color Doppler ultrasound images with the holding breath in inspiration and expiration, it is easy to see the difference. In expiration, flow in the left renal vein is very stagnant, indicating more severe compression effect. In this spectral Doppler ultrasound, these areas of high peak flow velocity around 180 as the expiration phase, and these areas with the peak flow velocity around 100 centimeters per second are inspiratory phases. Another example of respiratory variation showing the difference between the expiration and the inspiration images. Much severe compression effect in expiration phase. Another interesting phenomenon is the relation with the body weight. This was an overweighted patient with fatty liver and mild Nutcracker phenomenon with peak flow velocity 102. This patient had a surgery for thyroid cancer and he lost several kilograms of weight. And follow-up ultrasound taken 6 months later shows much improved the fatty liver but the Nutcracker phenomenon with much higher peak flow velocity, 178. Now probably already you understood why ultrasound is the best in the diagnosis of the Nutcracker syndrome. I will show two cases where ultrasound was best in the management of the patient. This woman had left-flank pain, and the severe Nutcracker phenomenon was found in the supine posture, and the left renal vein compression was much relieved in left lateral decubitus, but is not relieved in right lateral decubitus posture. She used to sleep in a flat supine posture and was asked to change the sleeping posture to left lateral decubitus, and she did, and her left flank pain disappeared in a week. In this case, definitely ultrasound was the best in the management of the Nutcracker syndrome. This is a case in whom the aspirin was helpful. She had microscopic hematuria and the left flank pain, and shows Nutcracker phenomenon caused by compression by the right renal artery, and the peak flow velocity was 160. The aspirin was used, and the symptom of left flank pain was improved, and the follow-up ultrasound taken 2 months later shows decreased peak flow velocity from 160 to 111. WFUMB is having ultrasound the best case campaign on the website, and this is the Nutcracker syndrome case included in this campaign. You may join this the campaign by submitting your ultrasound the best cases to the WFUMB website. This is summary, the answer to those questions. How common is Nutcracker syndrome? Is quite common. How various? Is so various. And how interesting? It's very interesting. And I believe we all understand why ultrasound is the best in the diagnosis and the management of the Nutcracker syndrome. Thank you for joining this talk, and I hope you enjoy the webinar.